Having learned the individual steps of neonatal resuscitation in the delivery room, let us now understand how a healthcare worker needs to perform while in the delivery room. A primigravida is about to deliver a 33 weeks period of gestation. You are the person attending the delivery. Tell me, how will you proceed?
Is the amniotic fluid clear? Is it a singleton pregnancy? Are there any risk factors?
The amniotic fluid is clear. This is a singleton pregnancy and there are no additional risk factors. The team uses a checklist to identify and assemble equipment for warmth, clearing the airway, auscultating the heart rate, equipment for ventilation, oxygenation, intubation, and medication.
Is the baby breathing or crying? Is the muscle tone normal?
The baby is breathing. The baby has good muscle tone.
I would place the baby onto the mother's abdomen and simultaneously dry the baby so as to decrease heat loss. I would wait for 1 minute before the cord is clamped. I would remove the wet linen and wait for 1 minute. And I will do ongoing evaluation of the baby. 1 minute is over. The cord can be clamped. After cutting the cord, I would place the baby for ongoing skin-to-skin contact over the mother's chest. Cover the baby and mother with a warm towel. Place a head cap on the baby. Continue skin-to-skin contact and help the baby initiate breastfeeding. During routine care, I would continue monitoring for color, baby's breathing, and temperature.
The baby is not breathing.
Dry and stimulate the baby. Place the baby in proper position. And in case there are any visible secretions, use a suction catheter to clear off the secretions. Stimulate the baby. I would check for breathing and check the heart rate for 6 seconds.
The baby is apneic. The heart rate is 60 beats per minute.
I will have to begin positive pressure ventilation
with 30% FiO2
using either a self-inflating bag or a T-piece resuscitator, whichever is available. For positive pressure ventilation, I'll keep the baby in slightly extended head position. I'll place the mask over the mouth and a part of the nose. Ensure that it is of appropriate size. Ensure a seal and give 5 prolonged breaths. I will call for additional help and tell the assistant to attach a pulse oximeter probe. For visible chest rise, and ask the heart rate.
The heart rate is about 40 beats per minute. There is no chest movement visible.
I need to take some ventilation corrective steps. I will slightly reposition the baby and readjust the mask and give positive pressure breaths again.
There is no chest movement.
I will see for secretions and clear off if there are any visible secretions.
There is still no chest movement. The heart rate is about 40 beats per minute.
I will increase the pressure and continue positive pressure ventilation. Back 2, 3, back 2, 3, back 2, 3, back 2, 3.
The chest is now moving with positive pressure ventilation. The heart rate is 120 beats per minute. The oxygen saturation is 64% with occasional respiratory effort.
I shall continue positive pressure ventilation and direct the FiO2 adjustment as per the target oxygen saturation for preterm infants.
Now, increasing spontaneous respiratory effort, the muscle tone is improving, the heart rate is 140 beats per minute and the SpO2 is 74%.
Since the respiratory efforts have returned back, but the saturations are still below the desired target oxygen saturation, I would continue giving free flow oxygen till I achieve the target oxygen saturations. And I would simultaneously keep a check on the heart rate being monitored by the pulse oximeter.
The heart rate is 140 beats per minute with strong and consistent spontaneous respiratory effort.
I will gradually wean free flow oxygen and continue to monitor the saturations, the heart rate and the breathing effort for the baby. This baby now needs to be shifted to the neonatal intensive care unit for post-resuscitation care, and I will also utilize this time for updating the parents regarding the transfer to the NICU and further stay.